Hi class, this is Dr. Martino. This is the fifth video in the short PV loop series. In this PV loop mini lecture, we'll focus on something called congestive heart failure. And this will be left congestive heart failure. As always, we will begin with a normal left ventricular PV loop and modify from there. So congestive heart failure is a pathology where the heart is becoming more and more scarred, okay? More and more scarred through a number of things that could have happened to it. This individual might have had a heart attack, a myocardial infarction, may have had several heart attacks. It may be due to an increased systemic blood pressure that's been high, 120, under 120, over 80 is now considered normal. So this person has been at 145, over 100 for the last decade. That could, over that amount of time, make the heart continue to scar over. It gets bigger, but it's less functional. And so now they're in what's called congestive heart failure. Well, what happens? Okay, so again, we will start with this part of the curve. We will not deal, well, I guess we can. We can do it multiple ways. So we can deal with what happens with the diastolic curve. Okay, what happens with the diastolic curve, probably, now there's different things that can happen to this curve, is the curve is probably going to shift in this direction because the heart is now starting to stiffen. So instead of this being the route that this curve takes, the curve will now take a route that's something like this. Okay, so that's the first change. Now what happens? So we're starting in this corner. So normally you'd start in this corner, and because the amount of blood coming back and staying in the heart would be about the same. But during congestive heart failure, because the heart is getting weaker, what's ultimately already started to happen, and there are different levels. Let's say that this is mild congestive heart failure. The heart, the amount of blood in the heart will already be higher. So let's say that this is the new starting point. So the diastolic curve is shifted up because the tissue is becoming less pliable. There's a greater overlap of actin and myosin, which normally sounds good, but in this case isn't good. And the amount of blood left in the heart, in left chamber after every beat, is now higher by, let's say, 25 mils. There's more blood in the heart. Okay, so now you start asking yourself, well, what happens? Well, you ride up the curve, right? You ride up the curve as you normally would, and you'd ask yourself, what would happen to preload? What would happen to preload? And probably what is going to happen to preload in order to overcome this heart failure? Because your blood pressure has to go up, right? On the venous side, the veins are actually sending more blood back. Okay, more blood back. But the overall distance between here and here versus here and here is actually going to be shorter. Okay, so there's more blood left in the heart, and there's more blood coming back to the heart, but the overall distance between end diastolic, this point here, right, end diastolic and end systolic, is actually going to be decreased. Okay, so now you start to get isovolumic contraction, right? You start to get isovolumic contraction, and what starts to happen is that you're probably going to get about the same level of opening. It depends, there's lots of scenarios here, but let's stick with the increased blood pressure scenario. So you're going to get a slightly increased point at which, at which the valve opens, okay, because that's consistent with what's going on here. Okay, then you're going to have contractility, right? Well, what's going to happen? The preload is going to make this a little bit stronger, but remember the heart is actually weaker. So this is pathological situation, and the contractility is actually weaker, even though there's positive inotropes that are being released. Remember, this is what's called partially compensated or mild congestive heart failure. And so you're not going to get quite the same peak, right? You're not going to get quite the same peak. So you're going to get a lower peak because the heart is weaker. And what's going to happen is this congestive heart failure works like a negative inotrope. Okay, so the curve has moved in this direction. So then what happens is you ride down the curve and you come back to here. So your new PV loop in mild congestive heart failure, partially compensated for, is actually smaller, right? It's higher up. The diastolic curve is up because the heart is not relaxing as much in between. More blood is left in the chamber between each pump. Yes, more blood is coming in because of sympathetic nerve output increase. And yes, there's a small Frank Starling effect, but the contractility, the actual heart, there's less functional muscle because the muscle has died, right? And so you're going to get less of a peak, and ultimately this curve is a lot less than the original work, right? So your heart is able to do less work. Okay, so what happens if this continues? If this continues, what starts to happen is now you're going to get even more blood that is staying in the heart. You're going to ride up this curve a little bit higher, right? This is going to come out just a tad bit more. You're going to go up a little bit higher to have to overcome more pressure. The heart has now gotten weaker, right? It's gotten weaker. You now have another level of negative ionotropy, and ultimately now you have this curve, and this is medium, right? Medium to severe congestive heart failure, and you can go on, and this continues to repeat itself until the heart can no longer maintain perfusion, and you either need a heart transplant, you need to be put on external cardiac machine, or ultimately this will result in death. So that's essentially congestive heart failure. There's different scenarios. I've just given you one scenario. Obviously, as different things happen to different people, the curves will shift in different directions. But that's the basic gist. In Schoology, there's a hand-drawn set of these diagrams. In that case, I do not change the diastolic curve, and I keep the opening pressure of the aortic valve the same, and I do that to not confuse people, because now we're starting to get into pathologies here, and this is the most difficult of the PV loops that we're talking about because there's so many things you have to consider. So there isn't really one right way. There's just many right ways depending on the scenario. Okay, I hope that was useful. I hope that was interesting for you, and I hope you learned a lot. And again, just read, listen to the full lecture, make sure you go through each of these mini videos in sequence, and we have one more. We're going to deal with the right side of the heart. Once again, I hope this was entertaining. I hope you enjoyed it in terms of what you're learning, and I hope that it was useful. Thank you. Take care.